Now it's recording. Is everyone okay if I record? This is just for the other students that couldn't make it. All right, so just to recap, we're going over the syllabus. Welcome to Psychopharmacology, HNG 551. These are the readings. This is a summer course only from May 22nd all the way to June 3rd, so it's about 6 weeks, all right? It's going to be very condensed, and this is going to be your foundations course, so make sure that you try to keep up with the readings, because if you miss one reading or you miss 1 week, it's going to be a lot of material that you have to make up with, all right? The main book, once again, is the Enger book. It's a pretty straightforward book, but the style book and the static book is a lot more detailed. All right, like I said before, everything is fair game. So if it's in the readings, it could be in the exam, even if I don't cover it, all right? Because I only have about 90 minutes to talk to you guys. So these are the assignments. Case study number 1, it's already on the discussion board. It's worth 10%, and it's going to be due on June 1st, all right? Midterms are going to be on the 9th. Then you have case study number 2 on the 16th, which is worth 10%. Then you have the final exam, which is on 7/3/23. And then you have the NEI Master Psychopharmacology course. All right, I get it. The NEI Psychopharmacology course is pretty advanced, and there's going to be a lot of stuff in there that you might not understand now early on in your career, but as you guys progress to the clinical part, it'll all kind of make sense. All right, this is the topic outline. So week 1, which is this week, we're going to talk about, the neuroscience, pharmacology. It's kind of like the base of how everything's going to progress as the semester goes on. Then we're going to talk about mood disorders, major depression, bipolar disorder. Then we're going to go to anxiety, and then ADHD and developmental disorders. Then week 5, we're going to talk about opioids and substance use disorder. And number 6, it's going to be scheduled and non-scheduled psychoactive drugs. All right. So examinations are based on the required readings. Like I said, everything is fair game. Students have the option to take all exam and quizzes on site at the School of Nursing if they want during the business hours. The faculty reserves the right to randomly select students to be proctored for exams. And remember, like I said, exam grades are not rounded. All right, 82 is passing. If you get an 81.99, unfortunately, that's still going to be a failure. Okay. Yes, Jacob, question.
Hi, just to clarify, the exams are open the whole day until 11:59 p.m.
Let me clarify it with Peter Smith, but I believe so. But I'll get back to you with that. All right. I'll put it on the announcements once I get an answer for it. Okay. So these are the grades. Remember, exam grades are not negotiable. They will not be rearranged to accommodate anyone. So please plan. Remember, it's only a 6-week course, so we really have a lot of stuff to cover. These are the grades. Okay, so if you score 94 to 100, that would be an A. All right, congratulations if you can do that. 90 to 93.99 is an A minus. 86.89.99 is a B plus, and so forth. All right. I expect everyone here to strive for an A. Okay, minimum passing final grades is an 82, just so you guys know. Okay, if you have any kind of like issues or disability, please speak to the department and you can, arrange that with them if you need some accommodations. All right. Students who require assistance during emergency evacuation encouraged to discuss the needs with their professors. Okay. Obviously, academic integrity is very important. Remember, you guys are going to be, prescribers, and your patients are really going to rely on you to know your stuff. So always kind of remind yourself, I'm not just learning this because I want to get an A in the class. I'm learning this because I'm actually going to be affecting these people's lives. All right. So you're going to be the main chief, for instance, now. You can't always ask the doctor, quote unquote. Okay. So these are just, the citation. Make sure you read that. All right. Please do not cheat on the exams. So these are the outcomes. Upon completion of the course, you will be able to demonstrate analytical thinking and diagnostic reasoning skills in clinical decision-making with regard to psychopharmacology. All right. So we're going to talk a lot about like the book and textbook stuff, and I'll give you both sides perspective. Like in real life, this is what happens, but this is how you apply the stuff you learn in theory in clinical practice, right? That's important. So you're going to be able to integrate scientific findings from nursing and related sciences to improve nursing's care across diverse settings, integrating pharmacotherapeutics with everything else. Even if you're going to practice as a psychiatric nurse practitioner and not do, psychopharmacology, you should still have a good understanding of it. Teresa, yes, question.
Hi, I'm so sorry. There's a couple of students that are trying to get into the Zoom. I don't know how to help them.
Oh, they should just be able to go in. Let me see.
I know. How do I stop my hand? How do I unraise my hand?
I can lower your hand. It's fine. Wait, there's a few students that are telling you that they can't get in.
Yes.
Just log on.
Yeah. I kind of showed them the URL and the ID and the password. Christian was one of them, and Rosie was on a group chat saying she can't get in either. So I don't know how
They
to.
have to, you know what? They have to log in to Blackboard because their net ID is going to be linked to that. If they're just clicking on the link and they're not logged on,
Okay.
it's not going to allow them. You know what's happening probably? They probably have like personal Zoom accounts and they're logged on with their personal Zoom accounts, not the Stony Brook one.
I had that problem, and I just put in the URL. I told them to
Yeah.
put in the URL.
You know what they need to do probably? Let's clear the cookies
Mhm.
and then restart the page again. So clear the cookies and restart.
Okay.
Should be able to
Thank
get
you.
in.
Sorry.
Of course, no problem. All right, where are we up to? Number 2, demonstrate leadership and collaboration. Okay, recognize the role of the prescriber. So remember, everything's going to be a team approach, but you're going to be ahead of the team if you're the prescriber or the provider. Apply quality and safety principles with organization to be an effective leader and change agent. Integrate theory, evidence, clinical judgment, research, and interpersonal perspectives. Ethically utilize data, information, and appropriate technology to evaluate and achieve optimum health outcomes. Number 6, demonstrate political efficacy and competency to improve the quality of healthcare delivery. Number 7, integrate concepts of interpersonal communication, interprofessional communication, sorry. 8, synthesize ecological, global, and social determinants of health to design, deliver culturally relevant prevention, interventions, and strategies. Number 9, demonstrate behaviors of professional engagement and lifelong learning. All right. That's actually very important. Number 9. So you're always going to be learning. So even when you finish school, actually, when I've been practicing for about 5 years now, I really learned the most during my first year out of school, first year out of practice, right? But I did learn a lot in school as well. That was a lot. I can catch my breath. Any questions so far? Do you guys agree? Was that straight to the point? Right? Okay, please refer to your syllabus. If you have any issues with the syllabus, you can reach out to me. Reach out to me or Professor Smith. Let's see. What about lecture recordings? I have many days I must work on it. Okay. So these lectures are not mandatory. We are going to be recording them, obviously, but it's going to be interactive. So the lectures are kind of going to, I expect you guys to do the reading so I can clarify things that are not clear. Like my job here is not to recite everything that you guys read already. And honestly, the PowerPoints that I made them this morning because it's really not important. The PowerPoint is something that's guiding you, but really listening to what I'm telling you, listen to what I'm emphasizing. And these are going to be the clinical points, especially the fact that this is only a 6-week course. Try to get the main points. We're going to fill in details as you kind of advance with the program. All right. Okay, go to the PowerPoints. All right. Sorry. All right, so this is a course introduction. We're going to talk about neuroscience and talk about, pharmacology, obviously, psychopharmacology to be exact. I know most of you guys already took pharmacology, but, a lot of the concepts are kind of going to carry over. All right. So what is this? Everyone should know what this is, and you guys are going to get sick of looking at a neuron. Because really, this is what your meds are going to be working on. All right. So this is a neuron. You should know the parts of it because if a patient asks you how the meds works, you should be able to kind of explain it in a very basic sense if possible. All right. So a lot of the magic happens in the soma, right? The soma is where the nucleus of the neuron is, and that's where the genetic material is, right? So how does medicine work? What medicine does in a general sense is that it's going to have one presynaptic neuron talking to a postsynaptic neuron. And it's technically going to be, as Stahl says, the nucleus of one neuron is going to be talking to the nucleus of another neuron, right? The first neuron, which is called the presynaptic neuron, right, might actually tell the second neuron, okay, like you guys are learning from me right now, right? Please create a synapse in the hippocampus because I need to retain this material, right? And the connection can be very strong and it's going to be put into your long-term memory, right? It could be very short. It could be something in your short-term memory. The important thing is strengthening those connections, right? So they talk a lot about IPSPs and EPSPs. Anyone know what that is? What is an IPSP and an EPSP? What is an IPSP?
Calling me? Oh.
Please mute yourself if you're not answering my question. All right, so an IPSP stands for an inhibitory postsynaptic potential, right? So it's kind of like a signal that's telling that other neuron to kind of not have an action potential, to kind of shut it down, right? The opposite is called an EPSP. It's called an excitatory postsynaptic potential. And
hey, what's going on? You want to? Good.
please
You
mute
want to see your
yourself.
feet?
Yes.
Okay.
They're gonna get.
Please mute yourself, whoever that is.
Who is it?
Ramadan is a huge goiter that was reaching all the way halfway to the chest. So we opened the sternum,
Mm.
they got the goiter out, they got into the trachea. They repaired it.
You should be able
So
to
he's on
mute them
unison
yourself.
for that.
I see.
Which one's this in ICU? You said
Ramadan.
Tamadan. Oh, I see him. Okay, he's gonna come
Yeah.
up.
They're getting the big tube out today. We're gonna get the Blake out
Trying
tomorrow.
to mute that person.
And well, once he's ready for discharge, I guess we'll switch him to augmented from unison for just prophylaxis.
Okay. Like to Saturday and home Sunday, maybe?
Yeah, on Sunday.
There you go. Sorry, guys. All right, let's go back to it. It's good to know that someone with trach. That's great. That's good news. Okay. Can you guys see the neuron?
No.
No? Okay, hold on 1 second. On my screen again. Can you guys see the neuron?
Yes.
Very good. Okay. Going back to neuron. Okay, very good. So neuron is going to be the main cell that all the meds are going to work on, right? That's pretty much the central functional unit of the nervous system. All right. So like I said, you have a presynaptic neuron, a postsynaptic neuron, and all the magic that happens really is going to be the communication between the first neuron and the second neuron. A lot of our cells are going to be working on the postsynaptic neuron, whether it's going to mimic a neurotransmitter, right, that our body is creating, or it's going to be, you know, similar to it, right? Or it could be something that kind of, you know, blocks it artificially, all right? So the main part really is understanding that the soma is the cell body, the nucleus is going to be there, all the genetic material is going to be in the soma, and it's going to go down the axon, and it's going to terminate in the synaptic terminal, which is at the end, all right? The book actually calls it the terminal button. That's another name for it, all right? And also know where the axon hillock is. The axon hillock is actually where the axon, the part of the axon where the soma ends, in which the action potential is going to start, right? Remember, going back to physiology, it's going to open up sodium channels, right? Depolarize the cell. It's going to work its way down. And pretty much you have myelin there, which is going to protect the axon from leaking out the electric potential, all right? So this is it in like a zoomed out part. Okay, so you have the cell body of the presynaptic neuron. It's going to go down. And if you look at the zoomed in picture there, the action terminal is actually where, that's called the synapse. That's where the magic happens. All right. So if you look at the receptors, there's many receptors in the body. All right. You have dopamine receptors, you have serotonin receptors. The most abundant actually is going to be serotonin receptors. So if you look in the book, serotonin sometimes is called 5-HT. So if you see 5-HT, that means serotonin. And there's different subunits. You might have 5-HT2A, all right? You might have 5-HT1, you might have 5-HT1B, 2D, 3, 5-HT7. It gets confusing after a while, but, I do recommend maybe in this course now, it's going to be too much to like memorize and understand it, but it really will pay dividends later on when you start understanding all of the receptors, because when a pharm rep comes to you and says, we have a new medication, I don't know, it's a 5-HT2A antagonist, it's a D2 blocker. In your mind, you're already thinking, okay, this might be a potential treatment for schizophrenia, right? It blocks dopamine. It might have less EPS. It's a 5-HT2A antagonist, all right? If someone tells you it's an antagonist at the histamine receptor, right? What does that mean? Okay, there could be potential side effects of sedation, right? There could be weight gain. There'd be risk of falls because the person's going to be a little confused, right? If someone says it's an antagonist at acetylcholine, at the muscarinic receptors, which is in the brain, nicotinic is on the outside. You might think, wow, okay, there could be, anticholinergic side effects, right? Dry mouth, like urinary retention, constipation, all right? Blurred vision, all those side effects, just to give you an idea, okay? So if you look at the synapse there, you notice that, the neurotransmitters the release is kind of controlled. So you look at the vesicles. That's very important because we do have meds that work on the vesicles. Does anyone know what meds I'm talking about that actually works in the vesicles? I know it's a little bit ahead, but just in case if you guys were aware of it already. What medicine works on the vesicles, increases the release of neurotransmitters? Does anyone know?
Levodopa.
I'm sorry?
Levodopa.
It could, yes, that's one. Okay, what else? we have meds called VMAT inhibitors. So that's for tardive dyskinesia. When we talk about schizophrenia, we're going to talk about that as well. All right. So what they do is they reverse the vesicles and actually spits out neurotransmitters and actually reverses tardive dyskinesia. All right. Any questions so far? No. So if you look at A, B, and C, those are just, examples of reuptake. So reuptake means that your body wants to recycle neurotransmitters, right? It doesn't really want to waste. It's probably going to cost more energy to constantly make neurotransmitters, so it's much easier to actually just recycle it, all right? So we have a lot of pumps. We have something called serotonin transport pumps, which actually bring serotonin back when it's done being used, so it can be repackaged again. We have dopamine transport pumps, and we also have norepinephrine pumps, all right? So we have medications that work in that also. Okay, these are the types of neurotransmission, all right? So anterograde neurotransmission it's called classical neurotransmission. Classical neurotransmission because it's pretty much the standard. So it's a presynaptic neuron going to a postsynaptic neuron, right? Kind of moving from left to right all the time. But there is something called retrograde neurotransmission also, in which the postsynaptic neuron also communicates with the presynaptic neuron. Did anyone do the reading? Does anyone know, what proteins or neurotransmitters are actually retrograde neurotransmission? Anyone want to take a guess? Okay, one is endocannabinoids, right? It goes back from the postsynaptic neuron to the presynaptic neuron. Another one is nitric oxide. And another one also is called neurotropic growth factors. So the postsynaptic neuron will actually send growth factors to the presynaptic neuron, will kind of tell it to create new synapses, all right? Form new connections to other parts of the brain. And we also have something called volume neurotransmission. Anyone want to take a guess what part of the brain volume neurotransmission actually happens a lot in?
Is it the prefrontal cortex?
Correct. Yes, and the dorsolateral prefrontal cortex, it does have volume. Why is that? Why do you think it has volume neurotransmission? There's a few answers actually. Okay, one of the
Is
reasons
it because of the amount of sorry.
No, go ahead, answer, please.
The amount of receptors that is abundant receptors in those areas?
So there's actually not a lot. There's none or very little dopamine reuptake pumps actually in the frontal lobe. So when a presynaptic neuron spits out dopamine, it doesn't always get sucked up because there's not a lot of dopamine transport pumps. All right. It's called, sometimes it kind of looks like a puff of like when you spray perfume or cologne in the room, it kind of disperses out. That's pretty much how it works in the frontal lobe. So there's actually a false substrate, which actually dopamine is sent back up using the norepinephrine transport system. And the reason why that's important is because we do have medications for ADHD, which indirectly act on dopamine, but they actually don't affect the dopamine transport pump in the frontal lobe because, we don't have those there. So you give someone a med like Strattera, atomoxetine, right, which is a norepinephrine reuptake inhibitor. Or you give them, Wellbutrin, right, which is off-label, but it's a dopamine norepinephrine reuptake inhibitor. In the frontal lobe, it's going to block the reuptake of norepinephrine, but therefore it's going to keep dopamine there. If that makes sense. So we're acting on norepinephrine transport pumps, but it's affecting dopamine because dopamine relies on that to be reuptake into the presynaptic neuron. Does that make sense? All right. So anterograde neurotransmission is classical neurotransmission, which a presynaptic neuron will communicate. So it would be a electrical stimulus first, right, during that presynaptic neuron. And how does that signal go to the postsynaptic neuron? Obviously, the electrical stimulus would have to be converted to a chemical stimulus, right, which is a neurotransmitter, whether it be dopamine, serotonin, norepinephrine, those are the monoamines, right, or even GABA or glutamate as well, right? Retrograde neurotransmission is a presynaptic neuron communicating with a postsynaptic neuron, and then the postsynaptic neuron actually communicates back. So when the postsynaptic starts talking back to the presynaptic neuron, that would be considered retrograde. So you can remember retro, going back, right? Almost like going back in time. And volume neurotransmission is when one neuron is actually able to communicate to a neuron that's very far away. It doesn't have to be an anatomical connection on it, right? It can communicate to a neuron that's way out there because it's dispersing out. So you might spit out dopamine, and that's going to communicate to a bunch of other neurons that have that receptor for dopamine, all right? So these are the targets of psychotropic drugs. All right. So, 12 transmembrane region transporters. It just means that, the membranes go in and out of the cell membrane 12 times. That's why they called it that. And that's usually transporter proteins. So an example of a medicine that works on 12 transmembrane region transporter proteins would be, a serotonin reuptake inhibitor, right? Prozac, Zoloft, Paxil, Lexapro, right?
Okay.
Sorry, that was my smart. G protein linked. All right. So G protein link is about 30% of our medications. So those would be your D2 receptors, your 5-HT2A receptors. All right. Some of the other meds work on enzymes. So just in psychiatry, what two meds or what two diagnoses do we prescribe meds that act on enzymes? Anyone want to know? Extra credit.
Is it lithium?
Actually, that is one, but that's partial of what lithium does. So I'll take that as a correct answer. Yes, it does work on GSK3. But to be more exact, that works specifically on enzymes is actually acetylcholinesterase inhibitors, right? Which we use for dementia. So what it does is it stops acetylcholinesterase from breaking down acetylcholine. So you have extra acetylcholine to help with cognition. Another one is monoamine oxidase, right? So monoamine oxidase is an enzyme that eats up excess neurotransmitters. So in theory, you're actually increasing the amount of neurotransmitters in the synapse by stopping the breakdown of those neurotransmitters, right? So you'll have excess dopamine, norepinephrine, and serotonin. All right. So dementia is one diagnosis, which we use acetylcholinesterase inhibitors, and then major depressive disorder, we use monoamine oxidase inhibitors. All right. We don't use them as much anymore. I do still have a few patients that I prescribe monoamine oxidase inhibitors to. So with treatment-resistant patients, it is still a good medication to have, and you should understand how to prescribe it. Even though a lot of people are afraid to prescribe it, you should learn how to prescribe it. All right. The reason why people are afraid is because obviously it can cause there's a lot of dietary interactions with it. But if you use the patch, it's less because it doesn't affect the stomach. And it can cause something called hypertensive crisis, all right, if they mix it with other serotonergic meds. All right. Ligand-gated ion channels, all right, that's another form. So that would be what's a ligand-gated ion channel med? Benzos, all right, benzodiazepines. And voltage-gated ion channels would obviously be anticonvulsants, would be the main. So you have these five, and obviously right now it doesn't make any sense to you, and sometimes this might be extra information, but if you kind of understand the concepts of it, it kind of gives you an idea of how a medication will work, how long it might take. For instance, a G protein link receptor takes some time, right? Because there has to be cascades, right? There's second messengers, third messengers, and it goes all the way down, and it might take weeks for the medicine to work, right? But for instance, a ligand-gated ion channel works right away, all right? Like a benzodiazepine will work within 15 or 30 minutes, all right? Enzymes might take a little bit of time to work as well. Okay, so how do neurons adapt to medications? So, our brain is very smart. Our whole body is very smart. And sometimes when you block a receptor, it'll do something called upregulate. So for instance, someone has psychosis, right? So what will be the main treatment for psychosis? I would give someone a medication that blocks what receptor? Call it out. Antipsychotics are blank antagonist. Dopamine antagonist. All right. We're going to explore this more in detail when we talk about schizophrenia or psychosis, but the theory is in the mesolimbic area. We're going to talk about the dopamine pathways in a little bit. There's too much dopamine in the mesolimbic area. All right. So it's hyperactive. So what we do is we're giving them medications that block the D2 receptor in the mesolimbic area. So if someone's psychotic, you're giving them medication to kind of block the excess dopamine from binding to that receptor. But what happens? After a while, your brain is smart. And that neuron, that postsynaptic neuron, is like, wow, I'm not getting as much dopamine I was getting before. So what it's going to do is actually going to tell that receptor to start creating more dopamine receptors. So that's called upregulation. All right. And then the opposite can also happen. If something is being stimulated too much, right? That's the whole concept of tolerance, right? Why is it sometimes when you give someone medication, it doesn't work anymore? because you're innervating that neuron so much that the receptors will actually be overstimulated. What it does to protect itself from overstimulation is it downregulates. All right. So upregulation is usually when you give someone an antagonist, right? You block those receptors. The postsynaptic neuron is going to say, whoa, I'm not getting that same stimulation. Let's create more receptors, right? What also can happen is called sensitization. So not only is it going to create new receptors, it's also going to make those new receptors very sensitive. All right. Then the opposite as well. If you innervate a neuron too much, it also becomes desensitized, in which it might not work anymore. Similar to acetylcholine receptors, right? When you smoke a cigarette, after a while, it downregulates and you don't feel it anymore, right? So once again, upregulation is when you're blocking and it creates more receptors. Sensitization is similar to that in which the receptors are very sensitive. When you're stimulating a receptor too much, right, it's going to protect itself by downregulating, by probably removing receptors, or desensitizing, making those receptors that are there not as sensitive to the medication or neurotransmitter. Does that make any sense? Do I have to repeat myself, or is it clear? All right. So good examples of that, when you're prescribing a med and the patient says, hey, I've been taking this medication for, I don't know, 6 months, all of a sudden it's not working anymore. I need to go up on it, right? And in your mind, you should understand, okay, the reason why that's probably happening is because those receptors now, they're probably, if the medicine is an agonist, those receptors are going to They're going to downregulate, right? If it's an antagonist, those receptors are going to They're going to upregulate, right? That's how you remember it, or desensitize or sensitize. So this is called the agonist spectrum, all right? So normally in our brain, we have normal neurotransmitters, for instance, dopamine, right? It's a normal neurotransmitter. We need it for pleasure, we need it for drive, we need it for motivation, we need it for learning, but too much dopamine can cause psychosis, right? So when someone calls a medication or a treatment an agonist, it's mimicking the regular neurotransmitters that we have in our brain, right? So if someone is getting a D2 agonist, right, that medication is going to stimulate the D2 receptor the same way, endogenous dopamine is going to do it, right? A partial agonist also stimulates it, but only in a partial way, all right? Now, partial agonist could be a little confusing because it actually works two ways. What it does is actually, in a way, if there's too much receptor, let's say, for instance, if I give someone a dopamine partial agonist in schizophrenia, you would wonder, why am I giving someone an agonist if they're already psychotic, right? And the reason why we do that is because a partial agonist in the presence of excess dopamine or excess neurotransmitter actually works as a net antagonist. I'm going to say that again. A partial agonist, when given to a patient who has excess neurotransmitter, is going to work as a net antagonist, all right? So even though it's called a partial agonist, if someone has too much dopamine in the mesolimbic area, that partial agonist is actually going to bind to that receptor, competing with the regular neurotransmitter, and actually block part of that. So technically, quote unquote, it's going to be working as an antagonist, all right? Also, a partial agonist we give to people sometimes in depression. Let's say, for instance, someone comes to me and says, I have low drive, I have low motivation, all right? So I'm in my mind, I'm like, okay, that could be a dopamine issue. So they might not have enough dopamine in their mesolimbic area for pleasure, right? Assuming they don't have a family history of psychosis or anyone in their family has schizophrenia, I would be comfortable giving them a partial agonist to help. And what's going to happen is in that area in which there's not enough dopamine, that partial agonist is actually going to work as a net agonist. So it's actually going to stimulate it. So sometimes people refer to partial agonists as stabilizers, because when something is too hot, quote unquote, right, it brings the temperature down. When something is too cold, it'll make it a little bit warmer. Does that make sense? So a partial agonist, when there's too much neurotransmitter, is going to work as a net antagonist, which is going to, in essence, is going to be almost like a blocker, right? When someone doesn't have enough of a neurotransmitter and you give them a partial agonist, it's actually going to work as an agonist, and it's going to stimulate that neuron similar to an agonist. All right. Does that make any sense? Does that make sense? I know it's a little confusing at first. All right. So think of a partial agonist as a stabilizer. All right. And obviously an antagonist is going to block the receptor when something is too hot, for instance, right? You have too much dopamine, you're manic, too much dopamine, you're psychotic. We're going to give you a dopamine blocker. Therefore, we're going to regulate the excess dopamine release by blocking that receptor. What happens, right? The risk is that sometimes you block the receptor for too long, and then your receptors are going to upregulate, right? And those receptors will also become very sensitive. Okay. Inverse agonist. We don't really have many drugs that are inverse agonists in psychiatry, but an inverse agonist will actually work the opposite of an agonist. So if you read the Stahl book, the neuron will always be working still regardless, and the cascades will still be happening, right? Even if you give someone an antagonist, there's still going to be residual activity there. If you give someone an inverse agonist, that activity will actually stop regardless of what they. So the inverse agonist will actually stop that postsynaptic neuron from actually working and doing what it needs to do. Even if you give them an antagonist, there's still going to be residual activity in that neuron in which it works in a way that keeps it functioning. All right. Is that clear? Any questions so far? I know it's a pretty heavy topic, but we're going to build off this. All right, so this is the dopamine pathway that we were talking about. All right, we're going to explore this again in schizophrenia, but just to have an idea of it now. So these are the 4 main dopamine pathways. All right, like I mentioned before, the mesolimbic pathway is very important. All right, if we're talking about psychosis, the mesolimbic area is the part of the brain that's implicated when it comes to positive symptoms of schizophrenia or psychosis. So the dopamine theory of psychosis, if someone asks you, what is the dopamine theory of psychosis, right? Dopamine, you would say, dopamine theory of psychosis means that there's too much dopamine activity in the mesolimbic pathway. And what is the mesolimbic pathway? So the mesolimbic pathway is actually the ventral tegmental area, or the VTA's connection to the nucleus accumbens, right? Or the ventral striatum. So the connection of the ventral tegmental area to the ventral striatum is hyperactive, or is too hot, quote unquote. There's too much dopamine there. And hyperactivity of dopamine in that area is what's causing psychosis. All right. Mesocortical area. That's the connection to the dorsolateral prefrontal cortex, all right, or the cortex, quote unquote. All right. So the VTA goes to the cortex. So ironically, in that pathway, there's not enough dopamine. So we believe that in the mesocortical pathway with patients who have schizophrenia, there's not enough dopamine there. Therefore, that's why they're having negative symptoms, right? Negative symptoms could be, avolition, no motivation. They might have apathy. They don't really care. They might have no emotion, right? Avolition, no motivation to do anything. They might also have negative symptoms. They might feel like they have ADHD. They can't focus. They're forgetful. All right. So that's dysfunction of the mesocortical pathway. All right. So mesocortical pathway is the ventral tegmental area or tegmentum to the cortex. All right. Mesolimbic area is from the ventral tegmental area to the nucleus accumbens or ventral striatum. All right. Nigrostriatal area is very important because, our meds affect that pathway as well. And that's where EPS stems from. All right. So nigrostriatal area is where movement disorders come from. So you need dopamine to be able to move smoothly. So the way I'm moving my arms now very smoothly, right? If you give someone a dopamine blocker, what'll happen is they'll have Parkinsonism symptoms. So they might have condylar rigidity, right? Their arms are going to be very stiff. Might have something called dystonia, in which their neck muscles might get very tight. They might have something called akathisia, in which they feel very restless and they have to move around all the time. That all has to do with the motor pathway. So that would be the nigrostriatal area, in which technically you're giving someone an antipsychotic med that's going to block the excess dopamine in the mesolimbic area, right? But if you block too much dopamine in the nigrostriatal area, right, you're not going to have enough dopamine for movement. So that's why sometimes you give someone an antipsychotic and they might have symptoms of Parkinsonism, right? Flat-like faces, tremors, shuffling gait, right? Because that's all movement. Mesocortical area, like I said, not enough dopamine, negative symptoms, or cognitive symptoms. And the tuberoinfundibular area is important because sometimes you give someone a dopamine blocker. There's an inverse relationship between dopamine and prolactin in the brain. So inverse relationship means that when dopamine is high, prolactin goes down, right? And dopamine is down, prolactin goes up. So if you give someone a dopamine blocker and dopamine transmission starts going down, what's going to happen? You're going to give a patient something called hyperprolactinemia. And why is hyperprolactinemia not good, right? It's not good because long-term for females, they lose their period, right? Long-term, they might not be able to get pregnant. Long-term, they can also have osteoporosis, right? And they also can get something called the prolactinoma over time, which is almost like a tumor that has to be removed, all right? For males, hyperprolactinemia, you get something called gynecomastia, which is like breast growth. You might have leakage. You might actually start lactating milk as a male. You might have no sex drive. So these have serious implications for a patient. So which is why when you prescribe someone certain medications, you have to understand how it's going to affect the body, because that's how you're going to assess for side effects. And that's also going to determine what lab work you're going to order, right? So for that patient, obviously I would order a serum prolactin level and I would check it regularly. Just for your information, the meds that cause the most elevated prolactin is actually risperidone and paliperidone, or 9-hydroxyrisperidone. So those meds are notorious for elevating prolactin. Any questions so far? It's a lot of material. Please stop me if it's too much. We can always go down, go back. All right, we're going to stay with this because this is a very important topic. I didn't really write too much because I figured this should be a review from pharmacology, but really we could do a deep dive with this because this is very important. So what is pharmacokinetics? Can someone like explain it to me in their own way? What does pharmacokinetics mean to you? What is it?
The movement of drugs into the body system.
Okay, good. Anyone else?
It's like how your body accepts and processes the medication
Yes.
and gets rid of it.
Yes, very good. So pharmacokinetics, if you read the book, it says how your body affects the drugs, right? And there are 4 parts to it. There's absorption, right? How is it absorbed? Am I taking it sublingually? Is it given to me IM, right? Is it intranasal, right? All the different parts, IV. So all of that is actually going to determine how fast the meds are going to work, right? The potency of the medication, probably the risk of the side effects. Distribution is how is it distributed? Is it, is it lipid soluble? Is it water soluble? Depending on, obviously kids have more lipids. So, a lot of our meds are lipophilic. They love fats, right? So they tend to stay, if you want to. So a little bit of myself, I work child and adult psychiatry. So I do see kids as well. So with kids, you have to make adjustments to medications because, the medications are going to stay in their lipids and they're at more risk for side effects. All right. Metabolism, like we said, how is the drug metabolized? Some drugs need to be metabolized to an active form first, right? And it has to go through first pass metabolism. When meds have a very heavy first pass metabolism, what does that mean? First pass metabolism, what does that mean? You guys can think back to pharmacology.
Does it reduce the bioavailability of the drug?
Yes, it does, right? So meds that have meds that have a very high first pass, once you take it in, the availability is going to be very low, right? So sometimes those drugs you need to dose a little bit higher, especially if it has a high first pass, or we dose them differently, so it doesn't have to go to first pass, all right? And excretion obviously is, how is the medicine excreted out, usually through the kidneys, okay? So usually when I teach, because I teach clinicals also, I'll look at my students and I'll say, okay, a patient is not responding to a medication. Is it a pharmacokinetic issue or is it a pharmacodynamic issue? All right, what is pharmacodynamics? Pharmacodynamics is how does the medicine work in the body? So if I say something is a pharmacodynamic issue, maybe you're targeting the wrong receptors, all right? Someone is complaining of ADHD, but you miss the fact that they actually have a family history of schizophrenia, and you give them a stimulant which increases dopamine, and now they're psychotic. So that's a pharmacodynamic issue. You totally missed the target. You thought this person had ADHD, and you didn't do a good history, and then you find out that you woke up the genes, and now they're psychotic. All right, so that was a pharmacodynamic issue. A pharmacokinetic issue is that maybe they're rapid metabolizers, right, or ultra rapid metabolizers. And the medication is being taken in, and when you do a blood level, it's like 0 because the body is eating up the med so fast that it's not working. So it's a pharmacokinetic issue, right? Did someone get a Roux wire, right, or gastric bypass, and all of a sudden there's not enough, absorption area in the gut to get the medication, right? That could also be a pharmacokinetic issue. Okay, are they taking a supplement that's an inhibitor? Now they're having side effects in the medication, right? So I'm going to spend a little bit of time on CYP. What is the CYP system? Anyone want to tell me what it is? Did you guys read about it? Did you guys read it or no? Okay. So CYP enzymes are found in our body, and they're created mostly in the liver, but they're also found in the small intestine and the large intestine. You also have some in your stomach as well. And what it does is it starts breaking down the medications or transforming the medications. All right. There's many families in CYP system, but just for psychiatry, 2D6 is very important. A lot of our medications need a functioning 2D6 enzyme in order for the meds to be, metabolized or for them to work. All right. In all of medicine, it's actually 3A4. So if someone says this medicine is a substrate for CYP3A4, that just means that your body needs CYP3A4 in order to metabolize that medication. All right. If you don't have enough CYP3A4, what's going to happen? Someone gives you the medication and you're going to be prone to side effects. All right. If you have too much of it, you have some kind of genetic polymorphism in which you have too much 3A4. Someone gives you a medication that's 3A4, and guess what? It's not going to work, right? You would be considered a ultra rapid metabolizer. Okay. So I'm going to name some that you guys should really focus on right now. In the beginning, focus on 2D6 because a lot of our meds are 2D6 substrates. All right. In all of medicine, 3A4 is another one. 1A2 is another one. 2C9 is another one, and 2C19. I'll repeat that again. Don't worry about CYP because all of them say CYP in the front. Let's remember the numbers. All right. So 3A4, you should know what that is. What meds are 3A4 substrates. 2D6, know what majority of psychopharmacology meds are 2D6, and that will be a lot of our antipsychotics, some of our antidepressants. Beta blockers are 2D6. All right. 3A4 in psychiatry is important because benzodiazepines are substrates of 3A4. So if someone is a 3A4 poor metabolizer, what do you think is going to happen if you give them a Xanax? They'll be more sedated. Doesn't mean you can't give it to them, but you probably have to cut the dose in half. All right. Inducer is a medication or any kind of dietary or any kind of thing that you take that's actually going to cause your CYP system to produce more. So for instance, in psychiatry, carbamazepine is a very strong inducer. All right. I practically don't use it a lot. I do have a few patients on it, but I don't really start patients with carbamazepine. And the reason why is because it's such a strong inducer that it'll mess up the regimen of all the other meds that your patient's on. Because what it's going to do is going to increase the CYP enzymes and it's going to eat up all those meds. So what do you have to do? Probably double the dose or triple the dose of the medication that a patient's on. All right. So say they were stable on, I don't know, aripiprazole. They were stable on sertraline. And then, someone was like, you know what, they have trigeminal neuralgia, right? The neurologist is like, let's put them on carbamazepine. Now the patient comes back to you and they're depressed and they're psychotic and you're wondering what happened. Then you find out later on they were put on carbamazepine. So therefore you should understand that carbamazepine is an inducer. It's going to cause your liver to create more 2D6, more 3A4, and it's going to eat up all those other medications. Does that make sense? It's a big subject. I can go back again if you want me to explain that again. Does it make sense to everyone? Please, I don't want to leave anyone behind. These are very important. Any questions? Okay.
Actually, I have one quick question on that topic. So you said the 2D6 is important. Is
Yes.
that because it's mostly because it essentially metabolizes the active metabolite of drugs, or are there some psychiatric medications where, let's say, somebody who had an inadequate 2D6 system wouldn't be able to convert a prodrug into the active form?
Correct. Yes. So there are some medications, for instance, so if you guys don't know, I specialize in schizophrenia. That's like my bread and butter. I see schizophrenic patients most of the time, and I'm the one that sees most of the schizophrenic patients on my organization. So I use a medication called Risperdal, which is actually, Risperdal is a 2D6 substrate. Risperdal in a functioning person who has a 2D6, normal 2D6 metabolizer, right? Risperdal gets converted to something called Invega or paliperidone, or when you do the test, it's called 9-OH risperidone, all right? Which also has its own antipsychotic properties. So if a patient, for instance, needs a little bit of the 9-hydroxyrisperidone, because it does work a little bit different than risperidone, if I give them the risperidone and it doesn't get converted, therefore they might not respond to it. Does that make sense? So they might need the metabolite, which is 9-hydroxyrisperidone, to help with their psychosis. I can actually override that, right, by actually just giving them Invega, paliperidone, because it doesn't have, it's already converted. If I knew that they were a rapid metabolizer. Does that make sense? So 2D6 is important in that sense. And also 2D6 is important when it comes to tricyclic antidepressants. You need 2D6 also. So if someone is a poor metabolizer, or you give them an inhibitor, for instance, like, I don't know, chamomile tea. They're saying, well, now I can't go to sleep, so I need something to chill me out. I'm going to start drinking chamomile tea. And now all of a sudden, their nortriptyline is making them too sedated at night. And they say, now I feel terrible. I can't focus. I'm drowsy all the time. And you ask them, you know, is there anything that you changed in your diet? And they say, yes, I started buying sleepy time tea, right? Which is chamomile tea. Something should light up in your head. Okay, there you go. That makes sense. The reason why you're having these side effects before, which you weren't having on nortriptyline, is because you are taking a 2D6 inhibitor like, you know, chamomile tea, which is increasing the dose of your medication. Therefore, you're having side effects. Does that make sense? So it can get very complicated because obviously it's hard to really know all the inhibitors, all the inducers, what the genetic predisposition to a patient is. Are they naturally rapid metabolizers? Are they naturally slow metabolizers? You can do something called genetic testing. I do that with some of my patients to kind of see, and it'll tell me at certain enzymes, are they rapid metabolizers, and I have to double the dose. Are they slow metabolizers, and I have to cut the dose in half. All right, you can do that as well. Are they taking meds that are affecting that? So really, there's so many interactions. The best way to really know is do what? What do you do? What can you do to find out?
Check the table.
You can check the table, or you can do something with the patient. What could you do to the patient? You can have them do what?
Blood work.
Very good. Plasma drug levels. Very big on plasma. I do plasma drug levels for all my antipsychotics. All right. Because you want to make sure that the patients are, number one, are compliant, adherent, quote unquote, taking the medications, and that there's actually enough medication that's making it to the brain, right? Because if I wasn't doing blood levels, number one, I wouldn't know if they weren't taking the meds. And number two, I wouldn't know if the dosage is actually effective. So for instance, I'll stay with risperidone again, but you know, risperidone, usually the drug level, if you give someone risperidone 1 milligram a day, it hits steady state, right? Then you can do a level, takes about a week, would be 7 times the milligram dose. So if someone's taking risperidone 1 milligram a night and I do a plasma drug level, I should expect that steady state level to be 7 nanograms per ml, all right? If someone's taking 2 milligrams of risperidone, 2 times 7 will be 14. Now, if I do a blood level and someone's risperidone level is like 2 or 3 at 2 milligrams, 2 things could be happening. Number one, they could just be missing doses, not taking the meds, right? Or they could be on an inducer. Would they put on a med that's like omeprazole, right? Is also an inducer. You know, they're like, oh, wow, you know, my primary care doctor said I have an acid reflux. They put me on omeprazole, which is an inducer. That's why your meds are, that's why the levels went down, right? Or you got put on phenobarbital or carbamazepine, which are inducers also. That's why the level is down. Or you might just be a genetically fast metabolizer. I wouldn't know that. And the reason why I say just do a level is because there's so many factors that can affect drug metabolism, you know, genetics, diets, other medications that are put on board by other people, that you just do a level and you can adjust it based on that. All right. Just be careful sometimes, because if someone's on an inducer and you raise the dose, once they stop the inducer, what do you think is going to happen? Their dose is going to double or triple, and they could be at risk for toxicity or side effect. So make sure you warn them. That really happens with when we go to schizophrenia. We're going to talk about 1A2 inducers like smoking. The aryl hydrocarbons for smoking actually induces 1A2, which is an enzyme which breaks down clozapine. You might raise the clozapine level, and then all of a sudden they start smoking cigarettes, and then the clozapine level goes up, and they're going to be at risk for very bad side effects. It could also be deadly. All right. Pharmacodynamics, how the drug works in your body. All right. Usually we classify them as antagonists, right? When it blocks, agonists, when it simulates the same neurotransmitter, or partial agonist, right? Which is a stabilizer. That's it. That's all she wrote. I wanted to save the last like 30 minutes for discussion and answer any of your questions, because really I'm not going to read you the book, obviously, right? But these are the main bullet points that you should understand. So for instance, a test question might be a patient is taking this medication, right? And all of a sudden starts drinking tea, and the medicine levels go up, or the patient's having side effects. What do you think is happening, right? So the answer would be patient is drinking a tea that might be inhibitor of the substrates of that medication, therefore they're having side effects, all right? That could be a test question, right? Patient had a bowel resection. All of a sudden now the med's not working. What happened? That's a pharmacokinetic issue, right? Patient is given a medication for ADHD, all of a sudden becomes psychotic. Is that a pharmacokinetic interaction or pharmacodynamic interaction? Pharmacodynamic interaction. See where I'm going with these questions? Even though it seems very basic, you know, with all these concepts, I have like so many questions I can make for you guys, because the thing is, you need to kind of understand the practical point of it. You can't, you know, if you're just going to memorize drugs and say, okay, these are all the 2D6 substrates, risperidone, amitriptyline, nortriptyline, 2C19, Zoloft, Lexapro. It's you don't understand how to apply the concepts, and I'd rather you understand the concepts right now, and then we're going to review the drugs as you kind of have as you progress in your career and you guys move up to the clinical part of it, right? But right now, this is just the foundation, and I want you guys to understand that these are all the different interactions that can happen with the drugs. All right, partial agonist, like I said, a partial agonist in the presence of too much neurotransmitter is going to work as a net antagonist. All right, a partial agonist in the presence of not enough neurotransmitter is going to work as a net agonist. That's why it's called a stabilizer. Because when you don't have enough quote unquote neurotransmitter, you give someone a partial agonist, it's going to stimulate that neuron just a little bit because there's no neurotransmitter there, right? If someone's getting too much innervation from a neurotransmitter and you give them a partial agonist, what's going to happen? It's going to block that neurotransmitter. It's going to work as a net antagonist. All right. Anterograde neurotransmission, classic neurotransmission from a presynaptic neuron is communicating with a postsynaptic neuron. All right. So it's going to be an electrical stimulus, which is going to work down the synapse through sodium channels. And then at the end, it's going to be calcium channels opening up. It's going to spit out neurotransmitters and it's going to communicate with the postsynaptic neuron. And the important magic is going to be in the postsynaptic neuron's nucleus, which is in the soma. All right. So it's going to work through all those, you know, first messengers, second messengers, third messengers, you know, phosphorylation, all that stuff that they talk about in the Stahl book. And then it's going to cause that postsynaptic neuron to create a protein, right? That protein could be a scaffolding protein, which is going to tell that neuron to create more synapses, right? Or strengthen its connections to where it is already. Okay. Retrograde neurotransmission. The postsynaptic neuron is communicating back to the presynaptic neuron, right? An example, nitric oxide. Another example, endocannabinoids. Another example, neural growth factors. All right. So remember, retrograde going back is a postsynaptic neuron communicating with a presynaptic neuron. Okay. Volume neurotransmission works in puffs. All right. One presynaptic neuron is spitting out a bunch of dopamine. That dopamine is dispersing in the frontal lobe or dorsolateral prefrontal cortex, and they can innervate neurons that are actually far away. It's going to keep swimming because remember, we don't have dopamine reuptake pumps in the frontal lobe, right? We have norepinephrine transport, and it's competing with that. Therefore, not a lot of dopamine is going to get pumped back up. So therefore, you have a lot of free dopamine that's still going to kind of spit out and disperse out, right? Because we do need that dopamine tone for focus, right? You guys are listening to me right now. You guys are learning. If you had no dopamine puffs in your frontal lobe, you probably would be asleep, right? You wouldn't be focusing on me right now. Once again, just know the general sense of the neuron. I mean, I don't think I'm going to ask you questions about specifically, but if I do ask you, you know, where neuron is the nucleus, you should be able to tell me soma. All right. If I say, why does the electrical charge not disperse out, right? And your answer would be because it has Schwann cells or myelin sheath that's around it. Okay. Where is the neurotransmitters spit out? And your answer would be what? The postsynaptic terminal, right? Or the book calls it the terminal button. Okay, those are answers. All right. So I'm here. Ask me whatever questions you guys have. Anything that's not clear, I have no problem repeating stuff again or explaining stuff that you guys read. I really want you guys to read the book, because if there's anything that's not clear, we can discuss it now and talk about it.
Will we be getting like a study guide or focus point for the exam, or like will we also be having like a review before the exam?
What do you mean like a focus point, like what the exam is going to be on?
Like where to focus for the exam?
You know, it's going to be hard to, because it's such a big topic. I really want you guys to kind of understand. So, like, I'm not going to ask you guys like specific questions like, is Lexapro a 2C19 substrate or a 2A4 substrate, right? That's something that I don't expect you guys to memorize, but I do want you guys to apply knowledge. So the questions are going to be applying knowledge. And I really want it to be more clinical based. I'm not going to ask you guys definition questions. Okay. If you can understand the concepts that I'm telling you guys now and breaking it down, you should have no problem passing the exams. All right. If that makes any sense. I'm not trying to trick anyone. I'm not trying to make it harder than it should be. I just want you guys to understand the fundamentals of how to be, at this point, a decent psychopharmacologist, right? And hopefully become an expert psychopharmacologist when you guys start practicing.
And
I mean, I will, things I'm emphasizing now, if you guys don't get it, are going to be subjects of the test. But remember, it's not just me making the exam, it's also going to be Professor Smith. So, he can remember, everything is fair game. Anything that's in the assignments, you guys should read. And I'll tell you what, to make it fair, if you guys have anything that you guys forgot to ask me now and you guys want to send me an email, I have no problem emailing you back and explaining stuff to you. We're even sitting in for 5 or 10 minutes explaining it to you guys. All right. The point of this is for you to understand the concept that we're talking about.
I have a question for the exam. Like, for example, it shared like the beers criteria and stuff like that. Is that on the exam? Or are we really trying to focus on what the PowerPoint covers here?
So the Beers criteria is important because that's the meds that are very strong anticholinergic medication, right? So those are meds that can cause confusion, issues with memory. So I'm not going to ask you specific questions to the Beers criteria, but I might say on the Beers criteria, this med is classified as this. What could you do to alleviate? Maybe prescribe another med that's anticholinergic or something, all right? But I'm, just understand what the Beers criteria is for and why it's there. Does that make sense?
Yes.
Understand what an inhibitor does, what an inducer does. Understand what it means when I say someone is a poor metabolizer or ultra rapid metabolizer. Understand upregulation, downregulation, because that's really going to be important, especially when you start talking about meds not working for a patient who is actually taking the medication, or a patient who is having side effects from medication because they stopped it, because you can have withdrawal symptoms, right? That's the reason why we have withdrawal. If someone's taking a medication that's a D2 antagonist, right, and then the neuron is adapting by upregulating and becomes sensitive, and all of a sudden they stop the meds cold turkey and they're having withdrawal, you can tell the patient the reason why you're having this withdrawal because this is what the medicine does. Obviously in a basic sense, at least they understand, okay, I don't want to stop the meds because I can have withdrawal because this is how it works in my brain. So we should be educating our patients on what the general sense of the meds are doing. All right.
Professor Collado, can you hear me?
Yes, I hear you.
Hey, I'm so sorry. I was in and out of the lecture, so you might have already told everyone this, but will you post this recorded lecture?
Yeah, of course. Yeah.
Okay. And so will it be posted this evening or?
Yes, if I can find out how to upload it. Professor Smith is the tech savvy one when it comes to Brightspace, so I'm going to forward it to him and have him post it.
Okay.
And
the slides as well, correct?
Because I'm sorry. Yeah.
The slides as well.
Yeah, I'll post the slides. Sure.
Okay.
How's it going for you? Because this is a little tough. Like a couple of us didn't know that we were going to have these on Friday. Like I was free this Friday, but going forward, the other ones, are we going to be able to have access to them all? Like next week, I can't sign on. Will we have access to all of them?
All of the videos, you mean?
Yes.
Yes, I'm going to do my best to have it posted by tonight so you guys have it.
Okay, thank you.
So these videos are all going to be as important as the questions that you ask me. All right, because obviously I don't want to recite things that you guys should be reading already. So if we have engaging conversations, I know this is the first lecture, so I know it's kind of cold and you guys didn't know what to expect, but come prepared for the next lecture so we can really have deep dives and talk about it and explain it. Because, this is the best way to learn, especially since it's a small group, is like, sharing knowledge with each other and explaining scenarios and then talking about it over and over again. Because really in a clinical sense, that's what you're going to be doing as a prescriber, right?
And
yes, Elliot, question.
Sorry, yeah, just a quick question. Would you mind just reviewing one more time the partial agonists in relation to the concentration of neurotransmitters and how they can act as a full agonist or antagonist?
Yes. Okay. So a partial agonist, when given to a patient that has hyperactivity of a neuron, for instance, because it's being stimulated too much by dopamine, I'll use that as an example, is going to work as a net antagonist, right? So it's going to block it because it's too much. That's why it's called the stabilizer. if you look at the style book, he describes it kind of like a rheostat, where like you can adjust the lights up and down. So that's the best analogy, or one of the best analogies I've seen about it. So if you give someone a partial agonist, in theory, it should, when there's too much neurotransmitter, lower it down or block the net effect, right? Or when there's not enough neurotransmitter, actually give a little bit of stimulation when needed. So it actually plays two parts. Now, the issue with partial agonists sometimes is it's not always down the middle, all right? There are some partial agonists that are closer to antagonists, and there are some partial agonists that are closer to agonists. Does that make sense? So we do have 3 partial agonists in schizophrenia. We have the ABC drug. So just to name it, it'll just be a review once we talk about schizophrenia. You have aripiprazole or Abilify. You have brexpiprazole, which is called Rexulti, and you have something called Vraylar called cariprazine. All of them are in the same class. They're all partial agonists. But when you look at which is more of an antagonist, right, it would probably be brexpiprazole. Which one is closest to an agonist? It would probably be aripiprazole. And then you have cariprazine, which is kind of like in the middle. Right? Does that make sense? So think about it like science. Right? Some people might be like a point, I don't know, 38.5 inches or something, or 39. You want to have different, because the thing is, some patients might, if you give them too much of an antagonist, they might have extrapyramidal symptoms, right? They might have issues with walking. They might have stiffness in their neck. They might have elevated prolactin levels, right? But then if you give them something that's closer to an agonist, you might mitigate that. But the issue you have now is you give something that's closer to an agonist, you might actually worsen their psychosis, right? Because you might be stimulating dopamine too much.
Gotcha. Thank you.
Is that clear? Yeah. So it works both ways. A partial agonist can work 2 ways, as a net antagonist or a net agonist, depending on how hot or how cold that circuit is, right? So the circuit of the mesolimbic area is too hot. You give them a partial agonist, it's gonna cool it down. In the frontal lobe, it's too cold. There's not enough dopamine. You give them a partial agonist, it's going to make it a little bit hot by increasing dopamine there. Hoping to improve focus and negative symptoms of schizophrenia. All right.
Got it. Thank you.
Professor, can you go over the certain pathways with the dopamine theory in psychosis?
Yes. Okay. So I'm going to repeat it again so you guys can write it down. So the 4 pathways of dopamine is the mesolimbic area. So MESO, limbic, LIMBIGC area, because it's part of the limbic system. All right. And that's the connection of the VTA, which is the ventral tegmental area, connects to the nucleus accumbens, or sometimes nucleus accumbens is also called the ventral striatum. Right. So you'll know that the mesolimbic area, so because there's a dorsal and a ventral striatum, right? Dorsal striatum has to do with movement. So you'll never forget ventral, because just remember, VTA, V goes to V. Ventral tegmental area to the ventral striatum would be the mesolimbic area. Okay. That's implicated in positive symptoms of schizophrenia. So it's too hot, too much dopamine in the mesolimbic area. The next area is called the mesocortical area. So it's the ventral tegmental area once again, which is a little bit longer connection, which goes to the dorsolateral prefrontal cortex, or the cortex in short. So it's called the mesocortical area. Now in that area, when patients have, I'm just using schizophrenia, but there's other diagnoses that have not enough dopamine, also ADHD, depression, but just to keep it standard. In schizophrenia, there's not enough dopamine there, right? So we want to give just a little bit of dopamine, and sometimes we give them a partial agonist to help negative symptoms in the mesocortical area. All right. The next area is called the nigro, N-I-G-R-O, striatal area. Right. So that's the substantia nigra, which is one of the cell bodies that creates dopamine in the body. And that goes to the dorsal striatum, right? Dorsal striatum. So that's the movement area. And we need dopamine there, because if you don't have enough dopamine, you can actually have, movement disorders, right? Your movements are very stiff. You might have akathisia, feeling restless. You might have dystonia. You might have dyskinesias, which are involuntary muscle movements, all right? Or Parkinsonism, flat-like faces, shuffling gait. That's all movement disorders. Now, sometimes in a nigrostriatal area, you also have too much dopamine, because remember, everything is kind of like a balance, right? There's not enough dopamine, you have this, or you have too much. So sometimes if you have too much dopamine in the nigrostriatal area, because that's possible as well, you might have psychomotor agitation. So those are the patients sometimes that you might see, they're very spastic. They move around quickly. They might even be aggressive. They might have disorganized behaviors. So in schizophrenia, it could be too high, in which they have psychomotor agitation, or it could be too low, in which they're having abnormal movements. All right. And then the last part is called the tubero-infundibular area, which is actually the pituitary gland connection to the hypothalamus. All right. So in that area, if you block too much dopamine, it's going to increase the release of prolactin, causing hyperprolactinemia, right? Which is not good, because if you're not pregnant, you're not breastfeeding, your prolactin shouldn't be elevated, because you can cause those long-term side effects for males. It could be sexual dysfunction, gynecomastia for females, amenorrhea, they lose their period, they can't get pregnant. Long-term could be osteoporosis. They also can have develop something called a prolactinoma, which they will need surgery to have it removed. All right. Things that can elevate prolactin, just for your information, sometimes rigorous exercise before the blood work can cause elevated prolactin. Anxiety can cause elevated prolactin. All right. Funny enough, nipple stimulation, right? So if they had sex the night before and that area was stimulated and they do prolactin level in the morning, it could cause elevated prolactin as well. Okay. So just so you know, just so you don't freak out. If someone has elevated prolactin, you can ask them those questions and see, did you exercise? Did you have sex the night before? Were you stressed out? And then you can kind of recheck it again and see what's happening. All right, quick review. Mesolimbic area, too hot in schizophrenia, too much dopamine. Mesocortical area, too cold, not enough dopamine, negative symptoms, cognitive issues. All right. Nigrostrial area, too hot, psychomotor agitation. Too cold, dystonias or abnormal muscle movements. Okay. Tubero-infundibular area. You block dopamine, it can lead to something called elevated prolactin, hyperprolactinemia, which can cause those side effects that we were talking about. Is that clear?
I just have for the tubular fundibular area, where would it more be like if we block the dopamine because we give a medication and then that is a side effect of it? Is that what's happening?
Yes, because another name for dopamine is actually a prolactin inhibitory hormone. That used to be one of the names of dopamine. So if you think about it that way, it inhibits prolactin, and when you're blocking it, you're not inhibiting prolactin, so you disinhibit it, right? Double negative, it goes up. All right, so you give a D2 blocker and it will cause elevated prolactin.
I have a question just kind of conceptually. So when you give something that reduces the dopamine, does it reduce the dopamine for all of those areas, or do we know different areas that the different drugs target?
Great question. The reason why we have a lot of side effects is because we can't do that. We can't target certain parts of the brain specifically, unfortunately. Because remember, once you take the medicine, it's kind of like throwing a wet blanket on someone's head, right? It's gonna affect the mesocortical area. It's going to affect the nigrostrial area, the tubero-infundibular. It's going to affect all those parts. Same way if you give someone Motrin, right? It inhibits prostaglandins and it doesn't cause pain, right? Pain, but at the same time, you need prostaglandins to secrete the lining for your stomach. So if you inhibit prostaglandins for pain, you're also inhibiting prostaglandins and you're causing stomach irritation because the prostaglandins are not secreting that. So that's same thing with antipsychotic medications. You want to block dopamine in the mesolimbic area, but you're also inadvertently blocking dopamine in the nigrostrial area, causing movement disorders. Sometimes you get lucky, right? Sometimes you get lucky and you give someone, I don't know, 2 milligrams of risperidone, and that dose is just enough to block the psychosis pathway and not block too much dopamine in the nigrostrial area, and therefore they're not having muscle movements. Or sometimes, you're unlucky, and then therefore you have to give them a med like Cogentin to kind of balance it out a little bit. So it's kind of like a seesaw. You don't want to go too heavy on one side because it's going to lift up. You kind of have to balance it out. Does that make sense, Lori? That's a great question.
Yes, thank you very much.
Right. So that's really the side of, so that would be considered a pharmacodynamic issue, right? You're targeting the right receptors on one side, but you're also targeting the wrong receptors on the other side, but that's outside of your control. We're going to talk about this a little bit more when we talk about schizophrenia, but just so you guys know, we kind of know how much dopamine we need to block in order to get an antipsychotic effect. So in general, we need to block about 65 to 80% of dopamine in general to get an antipsychotic effect. When they do PET scans of the brain, that's what it shows, right? When they give the medication and they do a PET scan, they'll see that the patient is not psychotic anymore, and they'll kind of look at that and say, okay, this medicine was able to block this much of the dopamine receptors, and therefore that's where we got that number from. When they do PET scans of the nigrostrial area, 80% about what causes movement disorder. So if a patient, for instance, needs 80% of their dopamine blocked in the mesolimbic area to get antipsychotic effect, right? And then you push up the meds to block 80% in the mesolimbic area. You're also going to block 80% in the nigrostriatal area, right? So what's going to happen? Those are the patients that have movement disorders. But if a patient, quote unquote, is lucky and you only need to block 65% of the dopamine receptors in the mesolimbic area, then you can get away with giving them a med, and it's not going to cause, hyperprolactinemia or, dystonia, because it's not going to cross that threshold in the mesocortical area. I mean, in the nigrostriatal area, right? Or tuberoinfundibular area. Does that make sense?
Could you go over the inhibitor and then inducers again? I think you did this before, but I just wanted to write it down.
I can repeat this as much as you guys need. Okay. An inhibitor is something that someone takes, right? That's going to stop the liver from producing the CYP enzymes. All right. Now you need the CYP enzymes to break down those medications. If it doesn't have to be turned to an active drug, all right? It doesn't have to be turned to a prodrug. So for instance, if someone is given an inhibitor and you don't have enough liver enzymes to break that drug down, what's going to happen? They're going to have worse side effects, right? Or they're going to have toxicity because you need those liver enzymes to break down the medication. A lot of times, it's not that significant because a lot of our drugs are broken down by multiple CYP enzymes. For instance, risperidone, which is majority 2D6, but there is some 3A4 activity there. So even if you inhibit 2D6, there's still a little bit of 3A4 that's going to metabolize part of the drug also. It's really the drugs that are only broken down by one CYP enzyme or majority by one CYP enzyme, all right, where you can have a lot of issues because if you block or inhibit that CYP enzyme, you can have really bad side effects, all right? So an inhibitor, you have to kind of think of it two ways. What's happening at the liver part or the GI part, right? It's inhibiting the creation of the CYP enzymes. Now I have to put in my mind, I need that CYP enzyme to break the medication down. Okay, so if I'm taking the medication and there's not enough substrate to be broken down by the CYP enzymes, what's going to happen? The plasma drug levels are going to go up, right? So what's going to happen? They're going to have side effects. The opposite, you give someone an inducer, right? An inducer is actually going to increase the amount of the secretion of the CYP enzyme. So if you give someone medication that is a substrate of 2D6 and you give them a 2D6 inhibitor, in my mind, I'm visualizing 2D6 inducer, more 2D6. The liver is making too much 2D6. What's going to happen to that drug? It's going to get eaten up by all that 2D6 and the drug is not going to have any effect, right? It's not going to work. So you got to think of it two ways. An inducer is going to eat up a lot of the drug, therefore it's not going to work, or you might have to double the dose or triple the dose. An inhibitor, right? There's not going to be enough of the enzyme to break that drug down. I have to cut the dose in half or even a quarter, depending on how much you need it's inhibited. Okay. It is important to know this too. Inhibition works faster than induction. And the reason why that is because once you inhibit something, it inhibits it right away, right? When you induce something, right, it takes time for the liver to produce or the small intestine to produce those CYP enzymes. So there's a lag period. There could be like a week lag period. So when you give someone carbamazepine, which induces its own metabolism, we usually don't do carbamazepine level until like a week or two after that, because it might be okay a week, but then 2 weeks later, it can induce its own induction and it's going to actually drop down. Does that make any sense? Because it's going to take time for your body to build up those CYP enzymes and then break down the drugs or the substrates. All right. So an inhibitor, too much drug because there's not enough CYP enzymes, more side effects or toxicity. An inducer will take some time and it's going to create more of the enzymes and the drug level is going to go down and there's going to be no response. Okay. Now, if it's a prodrug, the opposite is going to happen. Not to confuse you guys, but remember, a prodrug is going to be metabolized to an active drug. So if you give someone an inducer, it actually would be the opposite. You guys understand why, right? Because the enzyme will have to convert that drug to the active drug. So if you have too much of it, instead of breaking it down, it's actually going to create more of that drug that's active and you're going to have side effects. Think about that for a second. I know it's confusing. But when it comes to a prodrug, that's what happens.
And actually, I have one more question with this. What are the important CYP enzymes that we need to know? And then what exactly should we know about them?
Know that CYP enzymes are needed to metabolize and break down the medications. So you should know 2D6, that's the most important one for psych, but also know 3A4, 2C9, and 2C19 and 1A2. So there's 5 of them. 2D6, 3A4, 2C19, 2C9, 1A2.
Thank you.
Hi,
Let's have a
Professor.
general sense of you know, which ones are broken down. Yes.
Hi, can you please repeat again what you said about the prodrug and the concepts of upregulation and downregulation in terms of how it affects the receptors? Yeah, and the activity.
Okay, so a prodrug, means that a medicine is inactive until it's actually metabolized. So you would think normally when a medicine is metabolized, it's broken down, doesn't work anymore, right? So think of a prodrug as a drug that when you take it, when it's not metabolized, it doesn't work. It has to be metabolized for it to be an active drug. If that makes sense. All right. An example of a prodrug could be Vyvanse, lisdexamfetamine. All right. It needs to be activated when you take it through your stomach for it to work. Right. The reason why they made it that way is because if people try to ingest it, try to sniff it, or they try to inject it, the medicine active, it doesn't work. So it has to be converted as a prodrug when you take it. What was the other question? I'm sorry, Jacob. What do you want me to explain something else? I forgot.
Yeah, the upregulation and downregulation. I don't know if I was breaking in and out.
Sure. So think of upregulation and downregulation as homeostasis. All right. Your body always wants to go back to the state that it was before. So for instance, if your brain is used to getting a certain dopamine tone, whereas even if you're psychotic or not, let's say someone has schizophrenia, they've been psychotic for years or decades, right? Now you give them a dopamine blocker, their brain is going to say, whoa, what's going on here? You know, why is there not enough dopamine innervation? Because you gave them a drug. So what upregulation means that postsynaptic neuron is going to start creating new receptors on the cell. You're actually going to see new receptors kind of going up. So it's called upregulation because it's going to be increasing the amount of receptors, okay? Upregulation, increased receptors. Sensitization means it's becoming very sensitive. So the receptors that are there are going to be more sensitive to the neurotransmitter. That's why when you remove the drug and when they stop the drugs, not only do you have upregulated of receptors to deal with, you also have very sensitive receptors, which can cause rebound psychosis, right? But even more psychotic, or rebound, mania. And then desensitization means that when a neurotransmitter is innervating a receptor too much, it's going to become less sensitive to that, or it might even downregulate. It might start killing off some of those receptors because it wants to hit in homeostasis. All right. So too much desensitizes, downregulates. Right. You're blocking, it's going to compensate for the blockade by producing more receptors and becoming more sensitive. Is that clear?
So, in what instance would downregulation happen then?
Downregulation is an example if someone is abusing cocaine, right? They're saying, "Whoa, I can't. A gram isn't enough for me anymore, right? I need to use more. And I need to use more." So that has to do with dependence and tolerance, because tolerance technically means that you're not getting that same effect anymore. But in reality, if someone's getting benzos and they want to raise the dose, because the euphoric effect will hit a threshold eventually. The anti-anxiety effect will still be there. So be wary of a patient that's saying, "Well, the Xanax 2 milligrams is not enough anymore. I want to go up." All right. Is it because you want to clarify? Is it because you're not getting that euphoric effect anymore? Or is it because you're losing the anti-anxiety properties of it? Because in reality, the anti-anxiety effect usually stays and the euphoric effect goes down. But if they're chasing the euphoric effect because if it's obviously desensitizing, right, or downregulating, they're going to want to go up in the dose. And then what happens? The 5 milligrams is not going to be enough anymore because your brain's going to upregulate again. So you're kind of chasing something and there's no end to it. That's usually why benzos are not a good long solution. It should be used short term. And you should have an exit plan. So whenever I put not that I don't use benzos, I do use benzos, but I always tell patients, look, this is something that we're going to keep short term and we have to have an exit strategy because we don't want to get on that, where we have to keep raising the dose and you get a dependence and tolerance and we have to keep upping it. Then it's going to be very hard to get you off because by that time you'll be on 10 milligrams of Klonopin a day, right? And how do you wean them off? Very hard.
I have a quick question. I want to simplify agonist and antagonist. So if somebody needs more dopamine, an agonist would give or receive more dopamine. Is it that simple? And an antagonist.
A substance that's an agonist mimics the body's natural occurring neurotransmitter. All right. So, we have meds that stimulate dopamine. We have meds that stimulate serotonin. We have meds that can act on GABA or glutamate. So in a way, it's like a synthetic version, but it will stimulate it the same way that natural neurotransmitter does. Right. An antagonist is just an artificial, block that we're putting there because there's too much stimulation of that receptor.
Okay, thank you.
Come on, get your money's worth. It's only a 6-week course.
Hey, I'm so sorry. Can you hear me?
Yes, I hear you.
Hi, I was just curious if I could ask a question about the case study next week.
Okay. What about it?
I know it specifically said to cite for one of the things, but do you want it in like the official APA format or anything, or?
Yeah, it should be APA format. Yeah, all of your stuff should come in APA format.
Okay, so everything should be cited.
Correct. Yeah, cite as much as you can. Never oversight. Make sure you cite.
Okay, all right, and that gets posted to a discussion board.
Right.
Okay, got it. All right, thank you.
No problem. There's no silly questions. I'm sure if you have a question that you're embarrassed to ask, just ask it. Someone probably has it.
Can you just review quick the postsynaptic and presynaptic in that nerve transmission thing? I kind of have trouble grasping that.
Sure. So in psychopharmacology, right, we want meds that are actually going to work on the neuron. And normally how the neuron works is that you have a presynaptic neuron. So they could be millimeters, very short, or they could be very long. So in the dorsal raphe, which is where serotonin actually starts the cell body and the raphe nuclei, you have a very long neuron that actually goes up and it touches your cortex. So that presynaptic neuron is going to communicate with postsynaptic neurons in different parts of your brain. So it would start as an electrical impulse, right, which is the active potential, which you guys remember, right, which the cell depolarizes, becomes more positive. It works its way down the axon terminal. Towards the end, it's going to open up voltage-gated calcium channels, right? And the reason why it's important to understand voltage-gated calcium channels is because calcium influx into the cell is needed to spit out neurotransmitters, all right? And because the reason why you should understand that concept, because we do have drugs that we need when there's too much neurotransmitters. What happens when someone has too much neurotransmitters? Besides psychosis, what can happen? They can have what? Starts with an S. Seizures, right? So some of the meds that are anticonvulsants, they work on voltage-gated calcium channels, right? So when you work on those voltage-gated calcium channels and you stop the calcium from going inside the cell, you're going to stop the release of neurotransmitter. So someone who's having status epilepticus, or if someone's having a seizure and they have too much release of the neurotransmitter, you can actually one way stop that happening by blocking voltage-sensitive calcium channels, all right? So presynaptic to postsynaptic, in essence, is the presynaptic neuron's nucleus has to communicate with the postsynaptic neuron's nucleus. And that starts by an electrical impulse, which travels down the axon, down to the axon terminal, which spits out neurotransmitters. And the neurotransmitters are going to bind at what part of the postsynaptic neuron? Those little projections that come out of the soma. What is that called? Dendrites, all right? Dendrites. Then when it goes to the dendrites, and then that's where the magic happens, right? The cascade that's in the Stahl book will happen. The second, third, fourth messengers, phosphorylation goes inside the nucleus, transcription, right? Transcription of DNA to messenger RNA to translation to proteins to whatever it's going to be. All right, if that makes any sense.
So the cascade happens after the neurotransmitter reaches the postsynaptic receptor, right? Correct.
And depending on, now it also depends on what kind of receptor it is, right? If it's a G protein receptor, yes, the cascade will happen. It might take some time for all that things to happen. If it's an ion channel, it might be quick, right? Because an ion channel, once it opens, for instance, you give someone a benzodiazepine, right? You give them Xanax, fast acting. What happens? Xanax goes on an ion channel, which causes what? GABA to bind to the receptor. When GABA binds to the receptor, it's going to open up chloride channels, which is negative, right? Chloride is negative. And it's going to cause what? It's going to cause the cell to become more negative. So therefore, it's not going to depolarize and it's going to quiet it down, right? That's why people get sedated and they're calm. Does that make sense? And that works instantly. Not instantly, but quickly, relatively quickly, as opposed to giving someone, I don't know, risperidone. It's not going to get rid of the psychosis right away. It might calm them down because it's going to block the dopamine and nigrostriatal area, and they're not going to be able to be psychomotor agitated. But the actual psychosis might take, about 10 days at least for it to start working.
And for like the molecular targets, so like the 12 transmembrane, G protein length and stuff, do you need to know specific meds for those types of?
Yeah, of course. Antipsychotic meds work on the G protein receptors.
Okay.
Yeah.
No, I mean, like for the test, do we need to know like anything specific, or do we just need to know like the 5 targets?
Yeah, I'm not gonna I want you guys to understand the concepts. I know it's so I'm not gonna torture you guys. Don't worry about it.
Okay, thanks.
Hi, Professor, it's Dorota. So I have a question. In the list of things that we're supposed to cover in the first week, we also have a concept of synaptic plasticity,
Yes.
and second messenger systems and affect downstream events. Can you talk a little bit about it?
Yeah, I just talked about it when I was talking about the second messengers. Okay, but okay, so the downstream effects in essence, because it is complicated because there's many different messenger proteins, and I don't expect you guys to memorize the whole cascade because it is a little complicated with all the names. But just understand that there needs to be second messengers to work. And like I said, like emphasize the soma nucleus of the presynaptic neuron has to communicate to the soma of the postsynaptic neuron, right? Now, talking about synaptic plasticity, let's say, for instance, you guys are learning, right? You want to also in your hippocampus right now, you have a presynaptic neuron, which is communicating with your postsynaptic neuron, and it's telling that postsynaptic neuron to create, proteins that might be scaffolding proteins, right? Scaffolding proteins are proteins that connect different neurons to other neurons. So you're building extra synapses, all right? Does that make sense? So that's pretty much neuroplasticity. And things will always change. The concept about neuroplasticity is that something does not stay there if it's not used. So let's say, for instance, we're talking about psychopharmacology. So obviously during the 6-week course, we're going to be talking about meds and neurons and synapses. So it's going to be very fresh. And that concept will be kind of over time get strengthened and strengthened. What happens when you go a whole semester and don't think about it? In a way, those connections will get less, and that's when you forget about things, right? So they usually say in learning, you should always repeat things over and over again. They say, I think there's like a week after you learn it, a month after you learn it, and I think 6 months after, and a year after you repeat it. So you kind of reinforce that. Then it becomes long-term and then stays there for a long time or forever, right? The same concept with neuroplasticity, adverse childhood experiences, right, can also cause downregulation, not downregulation, but formations of bad connections, right? What happens if someone gets abused at a young age and, I don't know, by someone who is, I don't know, a 30-year-old Caucasian male, just an example. And that connection is formed when they're 5 years old. Now, therefore, when they're 30, now they wonder why. Why is it when I see someone who's like this, I get petrified, right? Or I get flashbacks because that connection was formed. Now, that's why you go to therapy, because what happens is sometimes you can't remove that connection, but what you can do is you can strengthen other connections around it. And you can kind of override that by strengthening the connection of your dorsolateral prefrontal cortex to remind yourself, this happened 20 years ago, right? I shouldn't be afraid now. And what therapy and medication does, it strengthens that connection of other parts of your brain to compensate for the mismatched connections. Does that make sense? So neuroplasticity is always in flux. Connections will always change based on experiences, based on meds, based on other issues, right?
Okay. Yes, thank you.
I'll go to 12:45 if you guys want, to ask more questions, and then I'm going to get off. So if you guys have any other questions, please feel free to ask. These are good questions. I don't mind repeating stuff over and over again so you guys get sick of it. It's the only way.
Professor, I just wanted you to clarify again the downregulation. I'm just not fully understanding how that works.
Okay, no problem. Okay. If you give someone Okay, downregulation. You stimulate something too much, it can cause something called excitotoxicity, right? So in order for you not to cause excitotoxicity to a neuron, the neuron will have to protect itself by downregulating because it's being stimulated by too much neurotransmitter. So it's going to reduce the amount of receptors, so the stimulus will go down. Does that make sense? So downregulation is if there's too much stimulation of those receptors, it's going to start reducing receptors so it doesn't get overly stimulated. It's the same as desensitization. So downregulation would actually remove receptors. Desensitization means that those receptors that are there are not going to be as sensitive as they were before, because it's trying to protect itself from becoming excited too much or too stimulated. If that makes sense.
Yes. Okay. And so, how does that happen? How's downregulation happen from the drug, from overexposure to certain medication?
Yeah. So the concept of downregulation and desensitization is such an important concept when it comes to addiction, right? Because the thing is, what happens when someone gets high of something, right? That initial high is probably going to be the strongest high they've ever gotten. And then they're chasing that same high, but they never get it. Why is that? Because the neuron is downregulating, and therefore they're constantly having to raise the dose to get that same high, but they don't get it because the neuron's smart. It's making the receptors not sensitive, and it's making it downregulate. Get it?
Yes. Yes. Thank you.
Which is why there's people now that do something called dopamine fast. Have you heard about that? It's called dopamine fasting, because they believe that, by using social media and having, YouTube and watching all these things, our receptors are so used to this dopamine rush all the time that little things are not as stimulating anymore. So they'll tell you, what do? Stay away from TV, stay away from, things that are too pleasurable, and you want to get your receptors to, downregulate and accommodate to that again. So therefore, when you get it, it feels great again, right? It feels novel again. That's why people take things for granted, right? I drive a Ferrari. All right, it's not enough for me anymore, right? Now I want a Lamborghini with, I don't know, 2 wheels or something. The novelty factor is always going to be, not enough. You always want that. That's because of downregulation and desensitization.
I did for the stalls reading. I know they went over like certain subclasses for like the transporters, like the 12 transmembrane and the synaptic vesicle. Do we need to know those like specific genes and like the subclasses, or not really?
No, I won't torture you guys with that. Just have a general understanding of it. That's all. Just
Okay.
know that if something works on ions, it's going to be faster, right? If something works with G proteins, it might take a little bit longer because of the cascade.
Mm-hmm.
So just a general idea.
I have one other question. So I was just reviewing the week one, and it said it also had inverse agonist. So antagonist and inverse agonist, the result is the same, but the way it acts is different. Could you just clarify that?
Yes. I'm trying to think how I can explain it easier with you guys. Think of like a leaky faucet, right? That's just leaking a little bit of water. So that's called residual activity, right? That's just there all the time. What's going to happen is if you give someone an agonist, it's like you opening up the faucet and now all that water is coming out, right? An antagonist means that you close the faucet, but it's still leaking. There's still residual activity, all right? An inverse agonist means that you actually are able to call a plumber and that leaky faucet is done. There's no residual activity. That's not really significant right now in clinical practice because, like you said, clinically, there's no difference in how the patients will react if you give them an antagonist or an inverse agonist. So at this point, I probably won't question you guys with that because it's not going to be clinically out, at least at this point.
Okay, thank you.
Psychopharm is going to be one of the hardest classes that you guys are going to learn. It's much harder than pharmacology. And that's because psychopharmacology antipsychotic meds or psychotropic meds are one of the most complicated meds in all of medicine. Right? If you look at, olanzapine, for instance, right? It's a D2 antagonist. It's a 5-HT2A antagonist. It's anticholinergic. It's antihistamine. It's 5-HT2C antagonist. 5-HT7 agonist, right? So it's like 6. I think I'm missing one more. But there's so many receptors that it touches because the brain is such a complicated organ that you kind of have to understand, what is happening here. Because people will come to you and they'll be on like 4 or 5 medications, right? And it's up to you to kind of decide, is it redundancy? Is it a pharmacodynamic issue? Is someone giving 2 D2 antagonists, and that's why the patient doesn't feel pleasure anymore, is having EPS? Are you giving too much anticholinergic medication? That's why the patient hasn't used the bathroom in like 5 days, right? Or they're sedated, or they have dry mouth or blurred vision. So these have really practical, implications for it. I really want you guys not to memorize the meds and just understand the mechanisms. It's kind of like learning a language, right? Because there's going to be many meds that are going to be in the same class. But if you look at the class, it's still going to be D2 antagonist, 5-HT antagonist. Because if we memorize meds, the meds will always change. Meds are pulled off the market, new meds are put on. But if you kind of understand the mechanisms, a pharm rep will come to me. I just want to know, I don't care what the name of the med is. Tell me the mechanisms. Tell me what the pharmacokinetic issues, right? Is it have a heavy first pass metabolism? What's the bioavailability, right? Is it a 3 or 4 substrate or 2D6 substrate? Right. So, I mean, these are things. And then just by them telling me that, I already have an idea in my mind what the potential therapeutic implications for this medicine could be. All right. I know this first lecture could be overwhelming. I get it. There's a lot of material, but we're going to be repeating stuff over and over again. All right. And obviously after the 6-week course, when you guys move on to 527 and 537, I teach those classes too. So I'm going to continue, breaking it down again and just keep reviewing it. I just want you guys to kind of understand the concepts now and start building now, so that when you guys get to clinicals, you're not overwhelmed with it.
I just want in the Kaplan book, they talk about like medications that induce akathisia, tardive dyskinesia, medications that induce tremor. So I just wanted to know like what would we be kind of responsible for? Because it just seems like such a broad thing.
In the SATIC book, it says that some meds could cause, well, in general, if you guys kind of break it down and remember what I told you, the dopamine pathways of the brain, right? So you need dopamine in the nigrostriatal area in order to move fluidly, right? If you're giving someone an antipsychotic med and you take that concept of what I taught you, that too much dopamine in the mesolimbic area can cause psychosis, and you're giving someone a med to treat psychosis, right? Obviously that med that treats psychosis can cause tardive dyskinesia, right? Because it's affecting the nigrostriatal area. Get it? So like, if you just look at it and take the big concepts and apply it, I think it'll be much easier for you guys. Instead of memorizing risperidone, hyperprolactinemia, right? Clozapine, less EPS, less tardive dyskinesia. Haldol, first generation, high Parkinsonism, right? Olanzapine, second generation. I mean, you can memorize it that way, but you're not going to understand it. It's kind of like you're missing the big point, which is understanding the concepts of the meds, not just the names of the meds. Are you guys overwhelmed? Be honest with me. Am I talking too fast? It's a lot of material, so I'm just trying to like fit it in. But like I said, I can repeat stuff as many times as you guys want. Raise your hand if you're overwhelmed. Only. All right, that's good. At least
I'm pretty overwhelmed.
It's all right.
Yeah, me too.
You know what? Anxiety is very similar to excitement when you look at it in the body. So change that mindset and you're not anxious or nervous, you're excited. It's a very exciting course. I'm very passionate about teaching it. I think for the past couple of years in Stony Brook, they kind of had the stall. So this is actually my first time teaching psychopharmacology to you guys. I've taught it in other places before, but I think this is important for you guys to understand that psychopharm is the building blocks, and it's very important to kind of get it right the first time and learn it right the first time. All right. I know it's overwhelming. Just keep repeating stuff over and over again. It'll make sense. Trust me, it will make sense. There's actually a few students here. I don't want to call them out, but I'm going to call out a few people that are actually auditing this class that are like 2 years ahead of you guys, or maybe more. Like Philip is there, Philip Ramirez. Philip, do you want to chime in and tell them your experience of how things were?
Well, we didn't have Richard when we took this class during the summer, so you guys are very lucky to have Professor Collado. It was very overwhelming, and it is very overwhelming. But you guys will get there. Like, you know, these concepts that he's going over now, you are going to hear again and again and again throughout throughout every lecture that you have, either, you know, in 517, in 527 and 537, not just, you know, in Psychopharm. So these are really great, like, you know, concepts to have a foundation, like, you know, like he said, but like, don't worry. I mean, you should worry about it, but it's going to be drilled into your head over and over and over again, so that like in a year from now, you can be auditing this class and you're like, you know every single answer to every question that, you know, that comes up. So yeah, the CYP enzymes are very important, I will say. So get those down pat.
So Phil, tell me, you're in 537 now, right?
Yeah, 537.
All right, so he's ahead of you guys. He can fill you in on what to expect. But it's exciting. Once you start doing clinicals, you don't want to start like seeing patients, even though it's clinicals, and second guessing yourself. So if you build the foundation now, it'll be a lot easier. Trust me. Like the hard work that you're putting out to understand the concepts will pay dividends later on. You're going to be jumping through hoops when it comes to, you know, prescribing meds and how to, you know, manage them.
Yeah. Are you guys using the stall, by the way? NEI?
Yeah, they have it. They have the stall.
Yeah, that is like game changer in my opinion. At least in the beginning, it was really helpful for me. So
What's the best way to use the NEI? Because I just see, like, you know, different things to click on, and some it's like, you know.
So NEI is great. It might be like a lot of levels above for you guys now, because think NEI, actually that program was made for residents, for psychiatry residents. So a lot of them have already taken this class. So it is challenging, I get it, because there's going to be a lot of stuff that kind of go over your head, but challenge yourself, do it. And the thing about NEI, the good thing is if you fail the test, you can just keep retaking it, take it enough times until you pass it. All right. It's just going to have to be reinforced over and over again. So NEI is going to be a little bit advanced, but you guys can always ask me, like, if something's not clear. You know, obviously, you know, there's going to be a lot of things there that you kind of, I'm not going to ask you, you know, give me the pathway of dopamine being created, right? From levodopa to all that other stuff, you know, but understanding the concepts of how reuptake pumps work, right? How it's recycled, and how reuptake pumps might help by keeping the amount of neurotransmitters in the synapse, therefore it might help depression or anxiety, right? Yeah. Like I really want this, I want everyone to attend these weekly like lectures, because it's really not a lecture, it's a conversation. I didn't really want it to be called a lecture, because it should be a shared conversation with us. Like, you know, obviously I'm going to share my knowledge and teach you guys, but, you know, by you guys talking, you guys are reinforcing stuff like over and over again and talking about it, you know, because obviously, you know, it's a lot of material, and, you know, by just doing it like this, it'll keep reinforcing it. All right, for everyone that's overwhelmed, ask me again, ask me another question so I can reinforce it for you.
Yes.
I
have a question that's not, it's about the NEI thing. My understanding, are we supposed to be taking the NEI Master Pharmacology program at the same time we're taking this, and then the test at the end is the final, or do we have a separate final and you want us to take this class?
Let me discuss that with Professor Smith. We're still trying to iron out details about that, but if you do well in the NEI test, you should have no problem passing the final for psychopharmacology.
Okay.
What's overwhelming about it? Like, tell me, what's overwhelming about it?
I think it's just like, just a lot of info. It's like hard to explain, but like I read some of the stuff, but then like I came on here and I thought I knew a lot about it, but then it was like more than I thought.
Are you a psych nurse, Brian?
Yes, I am.
All right. That's what happens with psych nurses too long. You guys think you know everything. I'm just kidding.
You know, it's funny because I was before I was a psych nurse, I was a float nurse for the longest time. So I did everything else but psych. And then I came to psych and it was like learning a whole brand new thing. Because you do psych a little bit, but not to the extent of what it is, you know.
You know, I used to be a martial arts instructor when I was younger, and I still do teach a little bit, but I'm going to teach you a wisdom. There was a guy one time that wanted to learn martial arts from another master, and he went over there and he said, you know, sure, I'll teach you. Let's have tea. All right, I'm paraphrasing a little bit. And when he sat down, he was like, okay, what's going on? Like, why are we having tea? I want to start punching things. I want to start kicking things. And the master was like, wait, so sit down. We're going to have tea first. So the master pours his tea. Then he starts pouring the tea for the other guy who wanted to learn. And he kept pouring the tea. And the guy was like, stop. It's overflowing. It's overflowing. And the master was like, look, see that? He was like, at that time, right now, you're not ready to learn because you're not ready to empty your cup, right? So as a psych nurse, you know, there are things that you thought you knew about psych, right? And there might be things you do know, and they're right. But in order to actually absorb this material, sometimes you have to kind of empty your cup per se and just come in it with a clear mind, all right? Any other things that you thought, you know, this doctor, psychiatrist doesn't know what they're doing. Why are they going up that high, right? Or they're not giving the patient enough medication. Why not just add Benadryl to this Haldol, right? Now you're going to understand why. And then you're going to appreciate it and say, okay, now I get why when this patient was out of control, the doctor was like, let's not give the Haldol, let's wait a little bit. Because the patient was probably having akathisia, right? Or was having dystonia when you thought the patient was like psychotic, you know? So it's like, it'll give you a different perspective. And I think you guys really will learn a lot in this course, regardless if you have psych experience or not, right? My goal here is just to kind of like expand your horizons and make you guys see that psychopharm is a very broad topic. And there's a lot more to learn once you finish. All right, we have 11 minutes. I'm going to give you your money's worth today. Professor Smith was like 2 hours, I think is too much for the students. And I was like, look, if they want to do 2 hours, I'll do it. So we'll see. We'll see who can actually challenge themselves and stay on it for 2 hours. Come on, any questions or anything that's not clear? I'll explain myself again.
Hi, I just had a quick question for the NEI. Is there, for us being students, is there any available promo codes towards that?
They should have gave you guys a promo code. They didn't give you one?
Yeah, I got an email actually, because I just activated my account, was it like 2 days ago because I was working, so I was trying to do just a couple just to see how it was. But yeah, they did send us an email. It's like $100 off or something like that.
Nice. Okay. All right. I'll look into that. Thank you.
Like I said, NEI is great. It'll definitely be like more than you guys need to know. But if you can challenge yourself and know the NEI stuff, you'll breeze through this class.
Download NEI Prescribe. That's my also suggestion.
Thank you.
No problem. I think this first lecture might be the most overwhelming. I'm hoping that the next few lectures will be a little bit easier because it's going to be more applicable, right? Because we're going to be talking about mood disorders. We're going to talk about schizophrenia, then ADHD, because then we can apply it to patients. So right now it's kind of like abstract because we're talking about neurotransmitters and neurons that you don't really see, you know, in real life. But I'm trying my best to make it as applicable as possible.
I think it's also tougher too. Hey, it's Jessica. Because sometimes your books don't come in time. Like one of my peers happened to have the book, so we were able to do the reading. But I think it's also like this first week is we didn't have everything that we needed right away, and then it's harder to speak to it.
Yeah, I understand. So hopefully you guys will have your books and we can have a deeper dive next week when we talk about mood disorders, right? Because you guys come prepared to reading. You'll really get the most out of it if you come prepared. Like if you're waiting for me to lecture you, then you read the book, that's the wrong way to do it. You're not going to get it at all. Like read it now and whatever's not clear, put notes that you can ask me and then I can, you know, clarify it for you, right?
Yeah, I was able to get the stuff through like a PDF, but like the psychopharmacology one was the author. The one that doesn't say review.
The Rettinger book you're talking about, the blue book?
Yeah, yeah. I paid for the expedited shipping and it's coming on Tuesday, so I got the refund for the shipping. But
I have PDFs for all the textbooks. So if you want to reach out, I can share them with you, with anyone who needs them.
Oh yeah, definitely. I'll shoot you an email, Jacob. Thanks.
If it makes you guys feel better, my job is not to fail you. All right. My job is to make you guys learn. But I will fail you if I feel like you're not understanding the stuff and you're giving me like not good assignments. All right. So I really want you guys to really challenge yourself and try to understand it and use me as a resource. All right. You can't, like, no one can say that I'm not giving you guys all like as much support as possible because you guys can reach out to me anytime, email me and I'll get back to you. right? Or we can do a quick Zoom call, like I said, to explain stuff.
Having this available is going to help too, because it's taking in like new information, processing it and applying it. And it takes a little time. But having this available is going to help me personally, I can tell you.
I mean, the lectures like this. I mean, the
Yes, yes.
Yeah. I think that was the main critique, Philip's class, their main critique, and the reason why we did this class the way it is now, because a lot of the students felt like there wasn't too much support and that, you know, there was no like live lectures. So in a way, I'm kind of like overcompensating for what the other course was, right? I'm giving you guys as much, you know, hands-on, I guess, right, as possible. This is the best way to win.
Yeah, thank you. It's very helpful.
Yes, thank you.
Thank you.
There's going to be a barcode at the end of this lecture. It's going to be my Venmo account. I'm just kidding. So, all right. So I'm going to cut it short because I know you guys are probably overwhelmed already. Just kind of, you know, think about the stuff that we talked about. If it's not clear, I have no problem reviewing it again next week. All right. Next week, we're going to talk about mood disorders, and we're going to do a deep dive on antidepressants and how they work in the brain and why we prescribe certain meds. All right. But the same concepts of inhibitors, inducers, fast metabolizers, upregulation, downregulation, that's always going to apply to all the meds. So even though you're learning it today, we're going to review it again. All these concepts are constantly going to be reviewed every week. All right. Okay.
The exam, just one more question. Is how many questions are going to be on it? And is it covering weeks 1, 2, and 3?
What I'm going to talk to Peter Smith today, Professor Smith, about it and see exactly how many questions there are. We'll send announcements to you guys. All right.
Okay. Okay. Thank you.
I mean, we have a general sense of what the test is going to be, but just to give you guys an accurate answer, just give me a little bit of time to ask him about it. All right. Okay. All right. Well, thank you very much. Very nice to meet everybody. All right. We're going to have a fun semester.
Thank
Take
you.
care.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.